Hi, Carmen. Thank you for that kind introduction. Good evening, colleagues. Can I just confirm that everyone can hear me properly?
We can hear you, Dr. Mahyoodeen.
Dr. Governor, could I ask, if you don't mind, I shared my version of the slides and not the one you have. I made a few minor changes. Would that be okay?
No problem. Okay, let me stop share. And
oh, I'm not able to share. It says you've disabled.
We'll sort that out now. We should be able to share now.
Here we go. Can you see this?
Absolutely.
Okay. What I'm going to do is just to make sure we don't have any other
You seem to be muted, Dr. Mahyoodeen. Would you unmute, Dr. Mahyoodeen?
Is that better?
Yes, now we can hear you.
Okay. So I had just begun by thanking Novartis and to you, Dr. Govender, and the rest of your Ecipa colleagues for the opportunity to speak to you this evening. The last 15 years have seen dramatic improvements in diabetes management, yet we all still struggle daily with the elusive holy grail of optimizing the various parameters in our patients with the metabolic syndrome and with type 2 diabetes in particular. I don't seem to be able to move the slides. There we go. When you look at this slide, it's actually the last slide I inserted into the presentation, only because one of my colleagues said to me that there's redundancy in my title and that all diabetics are actually difficult. And the truth is, she's probably right. Before I proceed to give you the outline of my talk, I think I'd just like to familiarize you with the disclaimer slide and to disclose to you that I have no conflicts of interest, even though I have presented educational talks for almost all the major pharmaceutical companies. So in terms of the outline of the talk this evening, I will begin by giving you a general overview of the epidemiology of type 2 diabetes with specific reference to Africa. And we'll talk about some of the challenges in type 2 diabetes. And I will briefly introduce you to the current type 2 diabetes guidelines. The bulk of the talk focuses on 3 case studies, each of which highlights a different aspect of diabetes management. The first focuses on a patient with hypoglycemia, and we will then move on to discuss an elderly patient with renal impairment. And lastly, the patient who would like to fast the Ramadan, and then I will go on to some brief concluding remarks. What I should also let you know at this point is that the first case presentation has a lot of data and theoretical background behind it, because this will then help us to answer the next 2 cases after that. What you see here is a map showing prevalence of diabetes across the world, and the source is, as you can see down here, the IDF Atlas. This is an important repository of information with regards to the epidemiology of diabetes. And what is important to note is that the prediction is that the global prevalence of diabetes will increase by more than 50% over the next 25 years, from 463 million to 700 million. What is even more sobering, however, is that in Africa, we are going to see an increase that is more than 3-fold what the global projections are. And in Africa at the moment, we have 19 million people living with diabetes, and this is data from 2019. And by 2045, this will increase to 47 million. At present, 3 out of 5 people with diabetes are undiagnosed, and 3 out of 4 deaths to diabetes are people under the age of 60. Also worrying is that younger patients with diabetes are more likely.
Dr. Mahyoodeen, some
Yes?
of the doctors are saying that your voice is quite soft. Can you
Okay, I'm going to address that. I'm just going to move the mic around. Okay, how is that?
Oh, that's wonderful.
Okay, sorry about that, colleagues. So the last point I was making is that in addition to the fact that a large number of people are undiagnosed and still living with diabetes, and that 75% of the deaths in people with diabetes are in people under the age of 60, young people with diabetes are more likely to be female. At one point, our understanding of diabetes was fairly simple, and it has significantly improved over the last 2 decades. Before the year 2000, the standard teaching was that hyperglycemia in type 2 diabetes resulted from a combination of insulin deficiency, increased hepatic glucose production via gluconeogenesis, and peripheral insulin resistance. All that patients required was lifestyle modification with metformin, and if they failed to reach the HbA1c target, you had the option of adding a sulfonylurea, a thiazolidinedione, or basal insulin, or a combination of any of these. But beyond this, there was little else to offer patients. We now know that this is a significant oversimplification. And in this century, Ralph DeFronzo described what he referred to as the ominous octet. And this gives us a better understanding not only of the framework of type 2 diabetes, but an understanding of where new therapeutic targets can be. So we no longer believe that it's just the pancreas, the liver, and the muscle that are important. We also know that hyperglycemia may be driven by the kidney, it may be driven by adipose tissue, and it can even be driven by central neurotransmitters and hormones that reside in the gut. In addition to this, we know that patients with type 2 diabetes actually have a low-grade pro-inflammatory state. And this pro-inflammatory state drives a lot of the complications of diabetes. So the question is, what can we do about this? So here we see some of the results from the STENO2 trial, which was conducted at the Steno Diabetes Center in Denmark. And what it has taught us is that intensive intervention in type 2 diabetes with multiple drug combinations and behavior modification has sustained improvements with regard to vascular complications and rate of death. We saw in STENO2 a 45% reduction in mortality, an almost 8-year increase in survival, an 8-year increase in the time to a cardiovascular event, and a significant decrease in the microvascular complications. In practical terms, what this means is that the multidisciplinary management of type 2 diabetes would involve lifestyle modification and smoking cessation, glycemic control, addressing body weight and obesity issues, treating the blood pressure appropriately, targeting lipid levels, in particular the atherogenic lipids being the low-density lipoprotein and triglycerides, and where appropriate to address the issue of platelet aggregation using antiplatelet agents. In 2017, the Society for Endocrinology, Metabolism and Diabetes of South Africa released guidelines. And as with all guidelines for diabetes, the basis of treatment is metformin together with intensive lifestyle interventions. However, I will go through the details of the censor guidelines when we discuss a case later. But what I would also like to point out to you is that these guidelines are now 4 years old and they require an update as there have been several important changes and important trials that have emerged in the last 4 years. And these landmark studies have changed the face of how we look at diabetes. The more recent American Diabetes Association and EASD consensus guidelines can give you a more detailed approach into how to handle a patient with type 2 diabetes. As I mentioned before, first-line therapy is still metformin with comprehensive lifestyle modification, which would include weight management and physical activity. However, then in going through the algorithm, one has to categorize the patients into those with atherosclerotic cardiovascular disease with chronic kidney disease, or those without established cardiovascular disease. In the high-risk category, one would have to determine whether cardiovascular disease predominates or heart failure or chronic kidney disease predominates. In the lower risk category, one would then make one's decisions around 3 major things. Is there a compelling need to minimize hypoglycemia? Is there a compelling need to minimize weight gain or to promote weight loss? Or is cost a major issue and the novel agents are beyond the reach of a particular patient? Now, we understand that we need to individualize therapy, and glycemic control is one of the many strategies required in the overall management of type 2 diabetes. But we also have to keep in mind that hypoglycemia increases complications in type 2 diabetes and increases cardiovascular risk. The impact of glucose-lowering therapies, however, is complex, and for an equivalent reduction in glycated hemoglobin, different drugs may have different additional benefits, pleiotropic effects, and adverse effects. So our therapy needs to be individualized and tailored to the needs of each patient. And even though we should strive for good glycemic control, intensive glycemic control increases the risk of severe hypoglycemia by 2 to 3-fold. So let me start with our first case. I'm going to present to you Mr. X. He's 45 years old and he works as a taxi driver. He was diagnosed with type 2 diabetes 6 months ago, and he has a body mass index of 25 kilograms per square meter. And just to contextualize that for you, this is just on the border of being normal weight to going on to overweight, because 25 is the upper limit of normal. And he is currently treated with metformin monotherapy. At his checkup, you find that he has a glycated hemoglobin of 7.5%, and he has no evidence of any complications. So my question is, what would be the next most appropriate step in the management of this patient? Now, to completely answer this question, one has to take into account a few things, and the considerations are, is the patient at the correct glycemic target? But more importantly, what is the ideal glycemic target for this patient? Are there any specific treatment considerations in these patients? And then which therapies could be considered in the management of this patient? So when we look at Mr. X again, we see that he's relatively young, right? Only 45, and he has new onset diabetes. Why am I so certain that he has new onset diabetes? Is we know he has no evidence of complications. So we would assume that this is recently diagnosed. However, perhaps he had it for a few years and has not yet developed complications. In the patient with type 2 diabetes, in whom we detect complications at diagnosis, you can be reasonably certain that this patient has had poor glycemic control for at least a decade. So we know he's newly diagnosed, and his glycated hemoglobin is at 7.5%. This doesn't seem terrible, truly. And in fact, if your practices are anything like some of our patients at Barra, 7.5% might even be on the lower side in terms of the spectrum of patients we see. But is 7.5% at the correct target? Also, we know that he works as a taxi driver, And in his line of work, a severe hypoglycemic episode could be disastrous. Now, the definition of severe hypoglycemia is any degree of hypoglycemia that requires third-party assistance for correction. So in this case, it could be, the consequences could be potentially dangerous not only for himself, but also for his passengers and other road users. So starting out with his target, the ideal target, according to most guidelines, is a glycated hemoglobin of 7%. And this target has been informed related to the evidence that the complications of type 2 diabetes supervene significantly when your HbA1c is raised above this level for a long time. And the data for this comes from the UK PDF study, which is a landmark study in type 2 diabetes. What you can see in this graph here, with the blue line showing us the microvascular endpoints, you see that just over 7% is where there is an inflection point. And in other words, the gradient of this line of the graph is much steeper, over 7% than under 7%. And you can see a similar pattern around 7% when they're looking at the prevalence of diabetic retinopathy. So what we've learned from UK PDS is that better control translates into fewer long-term complications. For every 1% decrease in glycated hemoglobin, one is able to reduce the deaths from diabetes by more than a fifth, reduce heart attacks by 15% almost, reduce microvascular complications by 25%, and to reduce peripheral vascular disorders by more than 40%. So what I'm demonstrating to you first and foremost is that an HbA1c of more than 7% increases the risk of complications. And even a small reduction, in this case it will be a 0.5% or a little more, will translate into better outcomes for your patients. But there is additional research that tells us we could be even more vigilant in this patient. He is a newly diagnosed patient with type 2 diabetes, and early glycemic control is key to the long-term decrease in complications in such patients. And this is a phenomenon that we know as the legacy effect. It's sometimes called the metabolic memory. Now, the data that is shown here comes from the long-term follow-up of the UK PDS trial, as well as the VADT. And in essence, what they looked at was the patients who were treated with intensive therapy in both of these trials had better outcomes in the long term, even after the trial ended, than patients who were in the control group. So in short, with early, strict glycemic control, and this refers to the first 5 years after diagnosis, has the potential to bring benefits and reduce long-term microvascular and macrovascular complications. And a bad legacy effect simply means that if you achieve glycemic control too late in the disease, in other words, after a prolonged period of poor control, the long-term risk of macrovascular complications is not improved. So in other words, what we're advocating for is that early good glycemic control, and the amount of benefits you can gain in those first 5 years after diagnosis is not something that can be reclaimed later. So if we consider our patient in relation to the South African guidelines, we know that his glycated hemoglobin is over 7% on monotherapy. So he would need to move on to dual therapy. And the preferred options, which are shown in green, are either the addition of a DPP-4 inhibitor, like voldagliptin, sitagliptin, or saxagliptin, or to use gliclazide MR. And I should highlight to you that gliclazide MR is a modified release sulfonylurea, which has a better hypoglycemic profile than some of the other sulfonylureas, particularly the older ones such as glibenclamide, but also some improvements over the newer ones. Thiazolidinediones and the SGLT2 inhibitors are alternate, but they are certainly not the preferred option in this case. Now, one of the things to notice is that the choices that were given were oral agents, and they were agents that would have a low risk of hypoglycemia. I'm sure you are all familiar with the signs and symptoms of hypoglycemia, but it is such a significant and potentially detrimental symptom, it is worth a mention. Now, the early symptoms are predominantly autonomic: hunger, tremor, sweating, irritability, headache, heart palpitations. But as the hypoglycemia becomes more severe, and we have what we refer to as neuroglycopenia, meaning deprivation of glucose for the brain. And there you have decreased cognition, confusion, seizures, ultimately coma and death. But the other thing I wanted to highlight to you is that hypoglycemia can also happen in sleep. And it's quite important to take a good history from our patients to elicit the presence of nocturnal hypoglycemia. This may include nightmares or night terrors, which happen at a particular time in the night or possibly in the early hours of the morning. Increased sweating, in other words, autonomic symptoms but leading to night sweats, or a feeling of waking up either confused or irritable or fatigued. What I have here, and I apologize that the slide doesn't have a title, is simply to demonstrate to you the mechanism of action of the sulfonylurea to show you why it would cause hypoglycemia. And you see that the sulfonylurea binds to a sulfonylurea receptor on the beta cell in the pancreas. And there are a series of downstream events looking at potassium and calcium channels, which ultimately cause insulin release. So sulfonylureas are, in short, insulin secretagogues. However, because they are relatively long-acting agents, they would work irrespective of whether the patient has had a meal or not. The incretins work slightly differently. Now, the incretins are not related to the beta cell specifically. They are released from the L cells in the terminal ileum. So they are actually gastrointestinal hormones. And their mechanism of action is slightly different. So the first thing to understand is that the main incretin, which we refer to as gluconlike peptide 1, is released from the small intestine in response to an oral glucose load. In other words, you will have no GLP-1 release unless you have had a meal. But active GLP has a very short half-life, less than 2 minutes, before it is degraded by an enzyme called dipeptidyl peptidase 4. So enter a molecule like a DPP-4 inhibitor, such as vildagliptin, and DPP-4 is inactivated, thereby increasing the active pool of GLP-1, allowing a slightly longer duration of action. Now, for our patient, what would be the next step? So firstly, as all the guidelines tell us, we would have to intensify lifestyle and dietary modification. We could also consider the addition of a modified release sulfonylurea, or the addition of a DPP-4 inhibitor. The additional benefit of the DPP-4 inhibitor in this case would be that it is a weight-neutral drug, unlike sulfonylureas. And in that instance, given that he had already had a BMI that was at the upper limit of normal, it may be a useful addition. Although it is possible to use SGLT2 inhibitors or GLP-1 agonists in a patient such as this one, there is no compelling indication to be using them at this stage. As far as GLP-1 receptor agonists or basal insulin are concerned, patients with newly diagnosed diabetes are often very reluctant to change to an injectable agent. So I have a few more slides to show you which are related to case 1, but I've included them after the main case to provide you with an alternate approach to a newly diagnosed patient. Now, the Verify study was a randomized controlled trial with a crossover design. And what they were testing was early combination therapy with metformin and vildagliptin, against metformin monotherapy. And if after period 1, patients had failed, in other words, they were not at their glycated hemoglobin target, then those patients who failed were moved into the combination therapy group. And if after the second period there was a treatment failure, patients were put onto insulin. So what did this trial show? What it showed is that the median time to treatment failure in patients on metformin monotherapy was 3 years. So as you can see here, this is the point of treatment failure, and they have gone above the line, and it took about 3 years. But those on combination therapy had a far longer and more durable response that went on to over 5 years. So it was over 60 months, and most patients were not yet at treatment failure. So what does this mean? Early combination therapy halved the risk of time to initial treatment failure versus a monotherapy strategy. 3 years in the monotherapy group versus over 5 years in the early combination strategy. And when all patients receiving combination therapy, the risk for a second treatment failure was also reduced, and that is data I haven't shown you. Both approaches were safe and well tolerated, but what it does show you is that there may be a more durable strategy to glycemic control in the newly diagnosed patient, provided, however, funding would allow it. Remember, this is not a strategy that is as yet endorsed by guidelines. However, it is an option for a patient who is newly diagnosed and would like a durable option that could last up to 5 years, if not more. The one disadvantage of this strategy, however, is that you will slightly overtreat your patients. So in that group who didn't ever fail in periods 1, 2, or 3, they may end up overtreated. And I think further studies would be needed to identify which patients would fall into that category. But the risk of overtreatment would be somewhere between 36 and 40%, if I'm not mistaken. Now, case 2 is Mrs. Y. She's over 70 years old, and she's a pensioner who lives alone. She was diagnosed with type 2 diabetes 3 decades ago. She has a body mass index that is in the overweight category at 28 kilograms per square meter, and a glycated hemoglobin of 8.5%. For some reason, so it says here her eGFR is 55 moles per minute, but I had actually intended for that to be changed to 35 moles per minute, but perhaps we can discuss both options. Also, she is known with hypertension, osteoarthritis, and has had a previous hip fracture, and as you can see, she has limited mobility. So currently, she's being treated with both metformin and sulfonylurea. So again, in order to decide what to do for this patient, we have to address the same 4 questions. Is she at the correct glycemic target? And what is the ideal glycemic target for this patient? What are the specific treatment considerations in these patients? And which therapies could be used in the management of this patient? So we know that she is in the elderly group. We know that her glycated hemoglobin is over the 7% target we spoke about earlier. We know she is overweight, and she has multiple comorbidities in there. And you can see where I've made an error. I changed it in one place and not the other. Her GFR here is 35 moles per minute. My apologies. But the question is, where do we go to from here? We said before that the correct or the target glycated hemoglobin is 7%. However, there are certain cases where you may want to adjust that, given the individual circumstances of your patient. And one of these is in the elderly, particularly in the frail elderly, those with multiple comorbidities, or those with significant renal impairment. Why? Because of what I told you initially, that hypoglycemia and the risk of hypoglycemia can increase up to 3-fold if we aim for intensive glycemic control. This target would not be the case for a younger patient, but certainly in the frail elderly, we can consider a glycated hemoglobin target of 7.5. to 8.5%, which may be more reasonable, more attainable without the risk of severe hypoglycemia. Now, the question next would be, what do we do for a patient like this? So again, the importance of intensifying lifestyle modification and diet cannot be overstated. But in this case, certainly, I would stop the sulfonylurea and metformin, particularly if her GFR was as low as 35. Could we add a DPP-4 inhibitor? And yes, there is good evidence that this class of drugs is useful in patients with renal impairment. In a drug like vildagliptin, however, it requires a dose adjustment. So instead of giving it to the patient twice daily, as one would ordinarily, you would give it to the patient daily if their GFR is below 50, and those with a GFR of over 50 can continue with it twice daily. Alternatively, you could add an SGLT2 inhibitor like empagliflozin or dapagliflozin, and there is very strong evidence that there is a decrease in progression of renal disease in patients on an SGLT2 inhibitor. And this would be either a drug like empagliflozin or dapagliflozin. Could you add a GLP-1 receptor agonist? And although the answer is theoretically yes, there would probably not be an additional benefit in a patient at this age. However, there is some data to suggest that GLP-1 receptor agonists may also decrease the progression of renal disease, however, not as significantly as the former class here, the SGLT2 inhibitors. And lastly, could you add basal insulin? I haven't ticked it off as an option, but certainly in a patient where you would need to choose an alternative therapy based on cost, and if a DPP-4 inhibitor or an SGLT2 inhibitor was unaffordable, then basal insulin is a reasonable option. However, in the patient on insulin, you would need to monitor them very closely. They would need to have a glucometer and monitor their sugars closely, and I would probably start at a low dose and titrate upwards towards correcting their fasting glucose. But again, tight glycemic control may not be achievable in a patient who is elderly and has renal impairment. So if you were to choose the SGLT2 inhibitor, what would you need to tell this patient about? One, there is a higher risk of both genital mycotic infections and UTIs. However, in the studies and in real world data, I think genital mycotic infections, so vulval and vaginal infections and balanitis are probably more common than the UTIs. You would also have to warn them about the potential risk of euglycemic diabetic ketoacidosis. However, this risk or the prevalence has not been as high as one would have expected. So the risk of hypoglycemic events when adding an SGLT2 with insulin or insulin secretagogue is certainly high, or if it is used in conjunction with the sulfonylurea. However, it doesn't have a hypoglycemic risk if it's used as monotherapy. And lastly, a diuretic effect will be observed because of the mechanism of action being a renal mechanism of action. So if these patients are also on a loop diuretic or another drug, those effects may be potentiated. So I'm going to move on to the last case now, which is going to be a fairly quick one. And the reason I bring this up is because we know Ramadan is starting in just 2 weeks. So we have a 55-year-old patient who is relatively recently diagnosed with type 2 diabetes, and he has a good glycated hemoglobin. He's also known with hypertension, and he's currently treated with metformin and sulfonylureas. And he asks you, can I fast in Ramadan? So the first thing I should warn you about is that if a patient is coming to you just 2 weeks before the month of fasting, he's probably coming to you 2 months too late. In order for our diabetic patients, ideally to prepare for the month of fasting, they should be evaluated at least 2 to 3 months prior to Ramadan, have their therapy optimized, and have any treatment and dose adjustments made beforehand so that they would be able to fast without any major complications. There is even the possibility of them doing a test fast before Ramadan, so you could judge how they would cope. However, be that as it may, we all know that our patients come to us later than they should. Before I carry on with the answer to this final case scenario, I also want to draw your attention to the Diabetes and Ramadan Practical Guidelines. There's an older guideline from a few years ago, and a new one has been released this year, which has been authored by Professor Mohammed Hassanein. It's an excellent, very user-friendly document, and it can be downloaded from the IDF site if you have any more detailed questions. But for this patient here, who is young, has good glycemic control, and is on 2 oral agents, probably the easiest strategy would be to continue with his sulfonylurea and metformin. However, you have to bear in mind that sulfonylurea is a hypoglycemic agent, and whether the patient has eaten or not, they will run the risk of hypoglycemia. So you may need to consider a dose reduction in the sulfonylurea, or if they are taking a twice daily dose, then to perhaps halve the morning dose and continue with the evening dose, or to switch the higher and lower doses around between morning and evening. The alternatives, a DPP-4 inhibitor. Certainly the patient can be switched to a DPP-4 inhibitor like vildagliptin, and there is data from the Virtue study on vildagliptin in Ramadan, where it shows that there is good glycemic control and it is safe and well tolerated in patients who are fasting. There are some practitioners who would consider switching the patient from a sulfonylurea to a DPP-4 inhibitor just for the peri-fasting period. So perhaps for 2 weeks before the month of fasting, during the month, and then shortly after the month before they switch back to a sulfonylurea, only to minimize the risk of hypoglycemia in this month. There is no data on the use of SGLT2 inhibitors in Ramadan, and given the diuretic effect, one would be concerned about dehydration. There is data for liraglutide, the Lira Ramadan study, which also shows that liraglutide is safe and well tolerated in patients during the month of fasting. However, there is still no contraindication in keeping him on his original drugs, and certainly there is no reason to change to a much more expensive and much more inconvenient drug if he is coping well on his oral agents. Certainly there's no reason to change to insulin at this point, but just a short warning about those patients who are insulin requiring and would request to fast. So the data for this has changed over the years, and it is not an absolute contraindication if you require insulin during the month of Ramadan. However, it does take intensive education and intensive modification of the insulin doses over time. So, to conclude, treating patients with diabetes encompasses numerous challenges, and the effects of glucose-lowering therapies are complex. We have several good guidelines that are available. However, in a patient with multiple issues, still a little bit of empiric reasoning is required in deciding on the optimal or ideal therapy for a given patient. And individualized therapy is integral to patient outcomes, to good compliance, and to an ultimate improvement in their quality of life. Ladies and gentlemen, thank you for your attention. I'm happy to take any questions.
Thank you, Dr. Nasrin Mahyoodeen, for a truly comprehensive, highly informative, and optimally paced talk for general practitioners. It is one of the best talks that we've attended to date.
Thank you.
You said in our initial discussion, you mentioned that you speak fast, but that's not true. It was optimal, so thank you very much. We highly appreciate it, and I'm sure our colleagues will refer to your slides to guide them in their practices. So thank you for that, and I would say at this stage, we look forward to hearing from you again. With that, we're going to open for questions. And I'm going to look to my two colleagues, Dr. April and Dr. Falkman, to look at the chat section. And I am going to go into the risky territory of unmuting everybody so that I don't have to jump around. Okay, so if you would want to pose a question verbally, please unmute and speak, or if you know how to raise your hand using the Zoom technology, you can do that as well. Otherwise, you can post your questions in the chat section and then we'll read it out. Let me see if there's anything in the chat section. No questions there. Dr. Mahyoodeen, if I may, and if you would just take out your pen and just make a note of these questions, there's a few. Firstly, comment on the phenomenon of thin fat people and how important it is in terms of metabolic issues. And what is the ideal BMI? We know the range is 18 to 25, but in your view, for females and males, if that has changed in any way? And what is the mechanism for potassium and sodium depletion when it occurs in diabetes? If you can just explain that. And apart from hypoglycemia, what are the other, if there are any, sequelae of overtreatment? And in general, what is the minimum HbA1c that one can work with?
Okay, those are all fantastic questions, Dr. Govender. So if I can simply start with the body fat distribution questions. So when you're talking about the thin fat, I assume you're referring to the metabolically normal obese patients. And what the data has shown is that even those patients who are obese and have no obvious complications initially, at some point they will decompensate. And the greater the likelihood of decompensation would depend on their family history and their risk of type 2 diabetes being unmasked. However, one of the things to keep in mind, and this leads on to your second question regarding BMI, all obesity is not equal, right? And body mass index is a very crude measure of how thin or how fat we are, because what it tells us is about weight for height, but it doesn't tell us anything about muscle mass. It doesn't tell us anything about the difference between visceral fat and the difference between subcutaneous fat. What we also know is that the different body fat reservoirs confer different risks in terms of metabolic syndrome. So, for example, a patient with a lot of visceral fat would have a higher risk, and a patient who has more gluteofemoral fat would have a lower risk. So in other words, the apple shape confers greater risk than the pear shape. So when you are assessing your patients, I think there are many research tools that are used to measure these accurately. You can do it by CT scan, by ultrasound, by DEXA scanning to get an idea of actual fat distribution. But in clinical practice, we have to do things by taking several measures together. Assess the weight, assess the BMI, but also look at the abdominal circumference. So an increasing abdominal circumference in someone who looks otherwise lean may be more worrying than someone who has a high BMI, but the BMI is based on a large fat mass, a large muscle mass. So I think don't underestimate the importance of using the abdominal circumference and the waist-hip ratio to assess the adiposity in your patients. Because in those patients who have a low waist-hip ratio, in other words, have more subcut fat, they may be at significantly less risk than a patient who may look otherwise lean and still have a disproportionately large abdominal circumference. I'm not sure if those two made sense.
Yes, it did.
Then your question was around overtreatment of or adverse effects in terms of the drugs. So, I mean, all drugs have prescribed dosages. So within their dose range, there are certain known adverse effects, but I don't think it would be wise to exceed the doses. The only drug that has no ceiling dose is insulin. And the only side effect really of insulin, provided your injection technique is fine, is hypoglycemia. So you would have to monitor them in relation to hypoglycemic episodes. And the thing about insulin delivery is it depends on the pharmacokinetic profile of the insulin you're using. And we have imperfect insulins, we know this. Short of a closed loop pancreas, you're not going to have perfect insulin delivery. So especially with the older human insulins, if you are going to use too high a dose, what happens is they reach a peak and then they go down. So in the time of that peak, as you keep going up on your dose, you are increasing the peak of insulin, which puts them at risk for hypoglycemia. But it doesn't cover the later hours in the day. So you have to actually figure out the pharmacokinetic profile of the insulins you're using and how they work in a particular patient. Then a minimum HbA1c. So that again will speak to the target you are using to treat a patient. In the patient who has long established type 2 diabetes, in other words, you've missed that first 5-year window where you would have the legacy effect, I would aim for an HbA1c of 7%. And as long as they are comfortably below that 7% margin, I think we're fine. In the frail and elderly, I am happy to be more lenient with those targets. And sometimes it is a reasonable thing to discuss these targets with patients. Some patients are happy to work to a tighter target and others are not. But when it comes to the lower thresholds of HbA1c, I think those would be reserved for the young patients in whom you are not worried about hypoglycemia. If you try to target a low HbA1c, you will have some hypos. They are almost unavoidable. It's even more true for the type 1s than the type 2s. So patients who are targeting a tight HbA1c should be prepared to test frequently. If they are able to afford continuous monitoring or the flash monitoring, that would make their lives even easier. And in that category, I would look at only the young patients with type 2 diabetes and those who have no comorbidities at all. Where it will become relevant is as we are picking up more and more patients with type 2 who are under 30, those who are adolescents and have type 2. Certainly, I think you could target a lower HbA1c, but your threshold for that lower limit is hypoglycemia and not a lower HbA1c limit.
Dr. Mahyoodeen, and then the mechanism of potassium and sodium depletion.
So I think that's not a straightforward question to answer. In fact, it's your toughest question, which is why maybe I just blocked it out of my mind. But electrolyte abnormalities in diabetes are more complex than a simple mechanism. Right? Remember, first of all, these patients can have renal impairment, which will cause electrolyte abnormalities such as hyperkalemia, not necessarily hypokalemia. They may also have renal tubular acidosis. They usually have a type 4, which gives you hyperkalemia, not hypokalemia, but may lower your sodium. In addition to that, although not necessarily common with our type 2 patients, but in type 1 patients, they may have associated Addison's disease, which again will lead to a hyponatremia and a hyperkalemia. And the one thing, if you have a persistent hypokalemia in a patient who has diabetes for no other reason, and remember, you would always have to look for iatrogenic causes for these because hydrochlorothiazide and furosemide are probably the top 2 causes in our metabolic syndrome patients for these electrolyte abnormalities. You'd have to consider Cushing's. That's only a partial answer to your question. It's probably one I'd have to read around a lot more to give you a complete answer, but perhaps I can.
So when is hyperglycemia, when they're not well controlled, you get a diuresis. Does that then cause a depletion of sodium? One tends to see that.
Yes, you may. So that is true. But remember, with hyperglycemia, you may also get a pseudo-hyponatremia.
Okay.
And with hypertriglyceridemia, you may also get a pseudo-hyponatremia. So it may also be analytic.
Thank you. Thank you for those responses.
Oh, and the other thing with sodium, sorry, Dr. Dutta,
yes,
is thyroid abnormalities is something to look for. Hypothyroidism in these patients can contribute to a hyponatremia.
Are there any questions? The colleagues? If there are no questions, could you comment on non-alcoholic steatohepatitis in diabetes?
So a lot of the data about NAFLD, and now they call it metabolic associated fatty liver disease, or MAFLD, is as being the leading cause of chronic liver disease and liver failure in the first world. The truth is, in South African studies, there is we have much less data, but in the few studies that have been done, there is a very low prevalence of non-alcoholic fatty liver disease, and I'm not sure why we don't pick it up as frequently. From a practical point of view, what are the ways to look for it? So first of all, is to have an index of suspicion in the patient who is obese, who has hypertriglyceridemia, who has poorly controlled diabetes. Could you pick it up on liver function tests? Maybe, but it would usually be late. So usually the liver function tests are normal. Ultrasonography could demonstrate steatosis, but not necessarily steatohepatitis. And the more specialized tests like CT and MR spectroscopy are probably not indicated outside the research setting. But what is becoming more and more useful is what is called the fibroscan. It's a process of transient elastography. And there are a few gastroenterologists who have been doing this in Joburg for probably about 5 years now. I'm not sure if it's available in Eastern Cape at the moment. But the fibroscan is a very sensitive measure of measuring liver stiffness, and it has a high sensitivity in NAFLD. So if you do have an index of suspicion, then fibroscan is the current gold standard for screening. But obviously the final or the ultimate thing to do is to biopsy the patient if needed.
But often we'll see patients with a high triglyceride, and shouldn't that one alert one to considering doing an ultrasound scan? What do you think? Again,
it would depend, right? Patients with poor glycemic control will have high triglycerides. So if you see high triglycerides, I would do 3 things. 1, make sure it is a fasting sample, because any meal can just raise your triglycerides. Make sure your patient is not on the contraceptive pill or some other drug that could raise the triglycerides. And then look at the rest of the biochemistry. Check the thyroid, check the renal function, and check the glycemic control. Because all of those secondary causes of hypertriglyceridemia are more important. And if after all of that is sorted out, the patient still has a persistently high triglyceride, then you need to address that, and you can consider the phenomenon of NAFLD.
And if you do an ultrasound scan and you pick up a fatty liver, what would be your approach to managing the patient? If the patient's not taking alcohol.
So if it is only steatosis in a patient who has the metabolic syndrome, and you have basically, remember, NAFLD is considered a hepatic manifestation of the metabolic syndrome. So your therapy would first and foremost be directed at addressing the lifestyle factors that have contributed to the fatty liver in the same way as you would be managing metabolic syndrome. So improve the glycemic control, improve the diet, reduce the, increase the exercise, and try and reduce the body fat mass, which will go a long way in terms of reducing those visceral fat depots. As far as pharmacotherapy goes, it's certainly not considered first line for steatosis alone, but there has been work done on pioglitazone, on the use of metformin itself, as well as now the newer agents are being explored in terms of fatty liver disease. But certainly, if you have confirmed fatty liver disease, my feeling would be that you should, and if you are noticing that it is progressive, to refer to a gastroenterologist or a physician, and also that the patient should be monitored for progression because fatty liver disease on its own is benign, but it's when you progress to fibrosis that it becomes irreversible, and that would be the thing to worry about.
Thank you, Dr. Mahyoodeen. I see Dr. April's hand is up.
Thanks, Doctor. Gavin here. SGLT2 inhibitors. Do you see them being a bit higher up in the list of diabetic drugs? Not so low down. You know, one would say metformin first, but wouldn't you think that the SGLT2 inhibitors should be perhaps a second-line treatment, if not a first-line treatment, in some high-risk individuals? Thank you.
So I think that where they should be positioned has to depend on what the evidence tells us. You know, in terms of an individual patient, if you were to say, if I was recently diagnosed with diabetes, what would I do for myself? May not necessarily be the same answer that you can support in a guideline document. And for now, the evidence for SGLT2 inhibitors is in the high-risk patient with either established cardiovascular disease, who has heart failure or is at high risk for heart failure, or who has renal disease, so chronic kidney disease. Should SGLT2 inhibitors be used primarily? Because remember, these drugs are not primarily used for their glycemic control. The improvement you're going to get in glycemic control with an SGLT2 inhibitor is possibly less than what you would get from a sulfonylurea, and definitely less than what you would get from insulin. So you're using them for their additional benefits. So you have to position them correctly so they are going to reach the patients who require them the most.
Thank you. Anybody else?
Thank you.
Thank you, Dr. April. Thank you, Dr. Mahyoodeen. Okay, it is now just 8 minutes past 8. I think, Carmen, okay, I see you coming. 8 minutes past 8, and I think we've had good discussion, an excellent presentation. Really like to thank Carmen for arranging and connecting you to us so that you could present to us, and we certainly look forward to further presentations from you. Thank you, Carmen. I'm going to hand over to you to do the formal vote of thanks, and if there's anything that I've missed out, please include it. Dr. Mahyoodeen, we wish you well, and trust that you will stay safe through this pandemic.
Thank you.
Thank you. Carmen?
We'd just like to extend our gratitude to Dr. Mahyoodeen for coming along, and I know it was a busy schedule for her with the SEMSA as well, to address the IPA doctors. We really appreciate it at Novartis. And then to our IPA doctors as well for your continual support from all of us at Novartis, and for always allowing us to get onto your platforms, Dr. Govender, and you can extend it to all the other doctors. And we also hope that this was of value to you, and that any feedback from you will be appreciated for future further meetings. And you guys must have a good evening and stay safe. Much appreciated, and thank you.
Thank you very much, Carmen. It was definitely value adding and highly appreciated. Thank you. Thank you to the Novartis team and to Dr. Mahyoodeen, and we bid you goodbye and rest well.